Thank you so much, Alexis. I hope you can see my images now. I have already opened the presentation. Okay. First of all, let me thank the organizers. Let me thank Echo System for organizing this. Mrs. Dana, who is always very efficient, and you, Alexis, for this invitation. I work in Milan University, Humanities University, and my agenda for this presentation includes these points. First of all, the ablation of thyroid papillary microcarcinomas, ablation of larger papillary and non-papillary carcinomas in unusual situations, ablation of recurrences of thyroid carcinomas in thyroid operative bed, and finally, ablation of nodal metastasis from papillary carcinomas. Of course, the first point and the last one will be the most important parts of my talk. Let's start from the papillary microcarcinoma. Microcarcinoma means smaller than 1 cm. Usually, they cannot be clinically evident, very rarely are clinically evident, may have or have not extrathyroidal extension, may be unifocal or multifocal. And as you can see in this graph here, you see that the incidence of this disease is significantly increasing in the years. And this is mostly due to the extensive use of thyroid ultrasound. You know, there were many discussions about the real need to treat micropapillary microcarcinomas or papillary microcarcinomas, but I will try to give you the current opinion about that. If you look also at the prognosis of this disease, we usually laugh when we say that if a person should necessarily choose a type of cancer for his or her life, he should choose papillary microcarcinomas, because as you can see here, the survival of these patients is equal, if not sometimes even better than normal people. What is the conventional treatment of Ptmc? As you know, you have two different positions. The first position is to leave the lesion inside the thyroid gland and simply follow up patients with ultrasound studies to see if it grows or if it gives nodal metastasis. But currently, the most underlined therapy is this one. Initial therapy is total thyroidectomy, followed by therapeutic neck dissection if there are nodal diseases. And in the evaluation of the postoperative disease status, when it is needed, the introduction of radioiodine scans. This is what is considered conventionally the ideal treatment. But nowadays, ablation has made a great entrance in this field. And my personal idea, my personal prospection is that in the next 5 to 10 years, most thyroid papillary microcarcinomas will undergo ablation. This is the very first paper published on that topic by a group of Italian doctors led by Professor Enrico Papini in Rome. And this is the first case published of a small lesion ablated. You see the cytological specimen on the right side. And 2 years later, the lesion is almost completely disappeared, and the biopsy of the residual part visible gives negative results, so no neoplastic cells any longer. And this patient was followed for 3 more years without any consequence. If you go on PubMed and you analyze you search for ablation of thyroid micropapillary carcinomas, you will see that from 2014 to today, September 2020, we find 33 papers, 27 of them coming from China, 4 from South Korea, and 2 from Italy. Dealing with RF ablation, 13 papers, usually with 16 or mostly 18 gauge probes, which are extremely good to treat lesions without any damage for the surrounding structures. 13 papers for microablation, almost all of them coming from China, and 7 papers regarding laser. Laser uses 300 millimeters optical fibers introduced into 21 gauge needles. What are the selection criteria for the ablation of these lesions? First of all, single tumor with a maximum diameter smaller than 1 cm. Preliminary diagnostic confirmation by fine needle aspiration biopsy or core biopsy, with no signs of capsular infiltration and no signs of extrathyroidal invasion on ultrasound. Absence of cervical lymph node metastasis studied with ultrasound. No distant metastasis, of course, on chest CT or chest MRI. And patient unsuitable for surgery or refusing surgical treatment. Patients without history of neck irradiation. This is because in this kind of patients, the papillary carcinomas are usually more aggressive, so they need surgical treatment. The importance of location. Location is very important because depending from the site, the location of the nodule, you may or may not use ablation. In the cases on top, purely, completely intrathyroidal. And in the second case, adjacent to the capsule but not invading the capsule, you can perform ablation. While in the third case down, with the perithyroidal fat invasion, for sure ablation is not recommended because you should also treat part of the lesion which is out of the thyroid gland. It means to treat also the muscles, the pre-thyroidal muscles in front of the thyroid gland, causing significant pain and scars to the patient. This is the very first case we treated in our department years ago, a 17-year-old female patient with a 9mm micropapillary carcinoma. She is the daughter of a very important radiologist, and the father decided that he would not have undergone his daughter to surgical treatment. He asked us to perform ablation. And this is the ablation during the treatment. You see the needle inside, 40 watts, 3 minutes, radio frequency, of course, and post-ablation CUS showing the black hole inside the thyroid parenchyma, and the 3-year follow-up demonstrates clearly that the nodule is almost completely disappeared without any sign of progression and any nodal metastasis around. Looking at the literature, I just selected 2 papers. This is a long-term result paper regarding microablation, of course, performed in China. Complete ablation in 40 out of 41 nodules. After 5 years, the median volume moved from 55.78 cubic millimeters to 0, with a volume reduction ratio of 99.33%. with hoarseness only in 2 patients. One of them resolved spontaneously in 2 months, the other resolved almost immediately. No recurrence, no metastatic cervical lymph nodes, and no distant metastasis. So excellent results. In this other paper, again, with a paper with a long follow-up of 5 years, it is performed in South Korea, RF ablation of 84 nodules in 74 patients, with a mean follow-up duration of 72 months. The complete disappearance rates were 98.8% at 2 years and 100% at 5 years. And additional ablations were performed only in 13 out of 84 nodules. We had in this follow-up, they developed cancers, new cancers in 3 patients, 4 cancers in 3 patients, again undergone RF ablation with complete disappearance. No local progression, no lymph node or distant metastasis, no patients underwent a delayed surgery, and the major complication rate was only 1.4%. But this is probably the most significant paper ever published on this topic, because it deals with as many as 414 patients, just recently published in European Radiology by a Chinese group. You see here the data regarding the patients. You see that the follow-up time is 42 plus or minus 11 months, and the mean diameter was 5.2 to plus or minus 1.5, with a volume, initial volume of 92 cubic millimeters plus or minus 83. The mean volume reduction was significant, from 92 to 1.37. The mean volume reduction ratio was, again, very significant, 98.81%. No major immediate or delayed complications. The complete disappearance was achieved at the first treatment in 88% of the tumors. And in the remaining 33, we had the persistence of small scars. It means, again, complete ablation, but still visible scar. Only in 15 cases, they had local tumor or distant progression, 3%, plus or minus 3%, with local tumor progression in 11 out of 15, and additional RF ablation in 13 of these nodules, with complete disappearance in 11 of the 13. So really excellent data in this huge number of cases. Just to show you just one case of this publication, this is a nodule followed on time, and you can see that when we reach 18 months, the nodule is no longer, absolutely no longer visible. Excellent result. And they concluded that radiofrequency ablation is an effective and safe alternative for micropapillary carcinomas. Let me move quickly to the second topic, ablation of larger papillary and non-papillary carcinomas in unusual situations. Of course, this is a more uncommon topic. There are very few reports on that. I start with two cases of our experience, occasional cases. This is a man, 73-year-old male patient, with a 17 millimeter single papillary carcinoma without cervical nodal metastasis. Of course, after receiving the result of the biopsy, we sent him to surgery. But the patient had an absolute refusal of surgery. This man read all the literature, the medical literature on this topic, and he said, I am conscious that the treatment ablation is usually reserved to papillary carcinomas smaller than 1 cm, but I don't want to go to surgery. So please do your best. I will sign every kind of agreement declaring that I am totally in agreement with this decision. And so we moved. This is the radiofrequency ablation. You see the treatment in the middle, totally vascular. 2 months later, the area is only 9 millimeter in size and is completely fibrotic without any sign of vascularity on contrast ultrasound. We should conclude from this occasional case that sometimes we could also enlarge our volume of treatments. We could include in our groups also cases with larger nodules, but we have to be very careful regarding the possibility of nodal metastasis or distant metastasis before starting ablation. This is a case we published recently in Endocrine. It's another very unusual case performed here at Humanitas in Milan. This is a 64-year-old female patient with a dramatic history of atrial fibrillation, dilatative cardiopathy with low ejection fraction, left hemispheric ischemic stroke, type 2 diabetes, chronic renal failure, history of endarterectomy for critical stenosis of the left internal carotid artery. And she was on therapy with lots of drugs for the many clinical situations. So when she underwent endocrinological screening, they found a calcitonin level of 647 picograms per milliliter. So we scanned the patient, the thyroid of the patient, and we found a 16 millimeter single medullary thyroid carcinoma. Once more, the main indication was surgical resection. But if you can read again all this, the dramatic history of this patient, we immediately thought that surgery was really difficult and at very high risk. So again, we asked the patient to sign an agreement, and she accepted. And this is the treatment. Before starting, you see the nodule, 16 millimeter, the ablation. 18 months later, the calcitonin is down to 15 picograms per milliliter. And as you can see here, on contrast enhanced ultrasound, the lesion is no longer visible. And on PET, CT, it is completely disappeared. I did not show you the image of the PET before treatment, but it was really dramatically uptaking. And so this is the result. Now the patient has reached a 2-year follow-up without any progression, and we will follow her for a long time. But we should also try to conclude that in particular clinical situations, ablation can be also taken into consideration for lesions different from the conventional papillary carcinomas. I remember to you that this was a medullary carcinoma. So, second topic, ablation of recurrences of the Fibroparative bed. This topic has been described in not more than 5 or 6 papers in the literature, because it's a really rare occurrence. And most of them, if not all, come from Korea, and most of them come from the group of Professor Beck, whom I thank for these images I will show you. This is a case of a patient with the history of thyroidectomy for papillary thyroid carcinoma, with a recurrent thyroid cancer in the left operative bed. You see the position indicated by the yellow arrow, just in the middle of the esophagus, laryngeal recurrent nerve, and sympathetic ganglion. So what to do in this case? Going back to the presentation of Professor Ming and Yu just a few minutes ago, they performed the same type of treatment. So they injected fluid, they performed the so-called hydrodissection, particularly in the posterior position behind the nodule, in order to detach the nodule from the ganglion and from the laryngeal recurrent nerve, with injection of 5% dextrose. And this is the result of the treatment, the 6-month result, significant, dramatic reduction in size of the nodule. This was before, and this is 2 years after the treatment, with the complete disappearance of the nodule without any local complication. Even more difficult, in recurrence of thyroid carcinomas invading the airways. All the surgeons know that this is one of the most difficult areas to treat, the invasion of the airways. In patients already undergone a thyroidectomy, sometimes also lymphadenectomy, is a really a very difficult challenge. The Korean group reports a number of cases in this particular situation. This is one of the cases I selected. Recurrent thyroid follicular carcinoma invading the trachea. You see that almost 50% of the trachea is invaded by this large nodule in November 2012. They performed a combination of SBRT and RF ablation. SBRT to try to limit the damage to the airways, and ablation limited to the periphery of the nodule. The 5-month follow-up shows an initial decrease in size of the nodule and a relative enlargement of the trachea. The 50-month means more than 4 years. Follow-up shows almost a complete return to a normal situation. There is a minimal part of a pathological tissue in the posterior part of the trachea. They performed a biopsy of that area, and it gave only fibrotic tissue. So apparently excellent result. These, of course, are very rare situations, but this is a possible treatment to be taken into consideration. You see here a summary of the few reports on this topic, RFA of locally recurrent thyroid carcinomas. And you see that the number of cases is not so significant, but it's important that the complications were extremely rare. We have only 6 cases in this group regarding voice change and 3 cases in the other group of limb. And for the other situations, no other significant complications. The overall complication rate in all these patients was only 10%. Remember that these are extremely difficult situations, sometimes inoperable situations. To conclude, ablation of nodal metastasis from papillary carcinomas. All of you know that thyroidectomy is very often associated with cervical dissection if there are cervical nodes, associated with radioactive iodine treatment to complete the result of the treatment. And that this is a not rare situation. You see here 2 different graphs showing the number of nodal metastases present in patients with papillary carcinomas. Of course, these are not micropapillary. These are usually large papillary carcinomas. Again, another table in another paper demonstrating the role of nodal metastasis on recurrence in thyroid cancer and in survival. And you can see that most of these patients had cervical metastasis, and these are huge number of cases. And most of them had an impact on local regional recurrence, and in some cases also an impact on the overall survival. So this is real and important and significant problem. And usually this is monitored after thyroidectomy and after lymphadenectomy and after radioiodine, measuring the serum levels of thyroglobulin, which is very sensitive. How much is the real risk of nodal metastasis from thyroid carcinomas? You see that the higher risk is for papillary carcinomas, but also follicular carcinoma. Carcinomas may have a good incidence of this kind of nodes. The mean incidence of nodal metastasis in these 6 papers is 28%. So lymphadenectomy is a treatment of choice, but complications rates are not so limited, particularly in patients undergone previous lymphadenectomy. Performing lymphadenectomy twice or 3 times is more and more difficult. This, I always say that this is one of the very few cases in which surgeons asked us to do something for them. Usually it is the contrary, as Alexis knows very well. We have taken cases from surgical department as interventional oncologists. In this particular case, our surgeons came to us years ago saying, can you help me? Can you treat these patients? Because performing repeat lymphadenectomy is a significant problem because of the scars particularly. So usually nodal metastasis can undergo, they almost always, if not always, have a significant FDG uptake. So PET is particularly useful to diagnose these metastases. If these metastases are also positive to iodine 131, they can undergo radioiodine therapy. But if they are negative for iodine, the only possibility is ablation instead of surgery. The very first paper published on this topic comes from the Mayo Clinic, from Professor Hay and Professor Charbonneau, using ethanol limited to papillary carcinomas, well-differentiated papillary carcinomas. And as you can see here in this graph, the results were extremely good at that time. At that time, the technique for RF ablation and for microablation was not so good. We did not have fine antennas and very fine electrodes. So ablation was really significantly invasive. Ethanol injection in this particular case gave good result. These are some other papers published on that topic by other authors. But if you can see the side effects on the left, on the right part of the slide, you see that they had some cases of mostly minor side effects. And the numbers are not so high of cases. Why? Because ablation came in, and thermal ablation came in. And this is one of the very first papers published by our group in cardiovascular interventional radiology in 2016, so 4 years ago. We treated 24 patients, 46 adenopathies. As you can see in the results, in 15 cases, 34 lymph nodes, one single ablation was enough to control the situation. In the remaining cases, we had situations of local tumor progression, which required a local retreatment with ablation, with very good results in most cases. And we had to exclude from the treatment only minor number of cases, 2 + 2, 4 cases in total, in which ablation was not enough to cure this, and they had to undergo repeat surgery. But the results were extremely convincing, and the time to progression was extremely long. So this is a case of a laser ablation, injection, pre-ablation on your left side, and 12-month post-ablation complete disappearance on PET of the nodal uptake. Another case, pre-ablation, post-ablation, completely black, avascular, pre-ablation on top, post-ablation down, complete disappearance of the nodal uptake, with a significant decrease of thyroglobulin from a value over 150 to almost 0. Finally, another case of a lymph node, significant lymph node with evident PET uptake in a 37-year-old female patient, PLA laser ablation with single fiber. We usually have a particular preference for laser for lymph nodes because of this unusual shape, elongated shape. With laser, you can stick the needle, the antenna, throughout the nodule from bottom to top or from top to bottom. Okay, this is the post-ablation result. Immediate 2 years follow-up, complete disappearance of the nodule uptake with PET, and fibrotic changes inside the remaining part of the nodule. I just report one more paper, initial volume of 92 cubic millimeter, mean follow-up time of 42 months. It's a Korean paper. And at the last follow-up, the mean volume was 1.37, 366 tumors disappearance, total disappearance in 21 cases at 3 months, up to 45 cases at 18 months, 54 cases at 24 months, and 11 patients at 36 months. So complete disappearance in 88% of the lesions. And these authors conclude, and I conclude my talk with this slide, that RFA is significantly useful for recurrent nodal metastasis with a significant volume reduction ratio, with the complete disappearance of the 82% of the lesions, a mean serum thyroglobulin level significant decrease, and RFA may replace berry picking surgery for recurrent papillary carcinomas, nodal metastasis from papillary carcinomas. This is the conclusion of my talk, and I thank you all for your participation.